Okay, so we will start the Q&A portion of our panel. Any questions from the audience? I know we have one via Zoom. Just want to remind those on Zoom that you can ask questions through the Q&A icon at the bottom of your screen. So any questions from the audience? Brendan?
My question is for Dr. Ganti. I think it's well known that the indications for adjuvant chemoradiation is extracapsular extension and positive surgical margins. But I'm always unclear on why we excluded like NK disease in that multiple lymph nodes. I know that that was an inclusion criteria for both the ERTC and RTOG.
So when they went back and looked at the role of adjuvant chemotherapy in patients with multiple positive nodes or any of the other factors that were inclusion criteria in both of those trials, when they did combine the two groups and did subset analysis, the only two groups that showed a definite benefit with adjuvant chemotherapy and radiation were groups that were patients who had extracapsular extension and positive margins. The other risk factors didn't seem to make a difference, or the addition of chemotherapy did not seem to help the other subgroups as much.
Okay. Question from Dan. She says, a naive question from a non-clinician. For HPV positive head and neck cancer, is HPV a causal factor? And would any screening or early intervention measures work for head and neck like Pap smear has changed cervical cancer? And I'll direct that to Dr. Zen and Dr. Ganti. I don't think Dr. Syed is on the Zoom call right now, so.
Yeah, so to answer the question, there's no really screening test for HPV positive for oropharyngeal cancer. But keep that in mind, actually, oropharyngeal cancer is very low. It's only about 12,000, cases a year in this country, so it's not very common. So, but we know now the vaccine works. So now pediatricians actually routinely recommend vaccination, and just like we use a vaccine for girls, but now we actually are starting doing vaccination for boys as well. But it's not very common. It's still a very rare disease. So there's no test like Pap smear for oropharyngeal cancer, and so at this point, really, it's a lifestyle. Basically, oropharyngeal cancer is a lifestyle-related disease because it's a sexually transmitted disease. So that good prevention really is lifestyle.
Okay.
This is Syed here. I'll just throw in one additional comment that there certainly are some salivary tests that are available to look for high-risk HPV in the oropharynx. However, none that are FDA approved, and we really don't know what to do with that data if somebody comes back positive. There have been some trials out of Denmark and some other European countries looking at patients who have had previous tonsillectomy or perhaps prophylactic tonsillectomy, whether or not that changes the course of HPV-related oropharynx cancer. And there's some data to suggest that at least decreasing the lymphoid tissue burden within the oropharynx may potentially have some protective effect, but nothing right now as far as a guideline change.
Well, thank you. For Dr. Ganti, this is from the Zoom audience. Is there a difference in the outcome of immune checkpoint therapy in HPV positive versus negative patients?
That's a very good question. Contrary to what we would have thought, HPV positive patients seem to respond better to immune checkpoint inhibitors as compared to HPV negative patients. The immune checkpoint inhibitors benefit both groups of patients, but the magnitude of benefit seems to be much more in HPV positive patients.
Thank you. Any questions from the audience? Dr. Enck.
So this was a question for Dr. Frederick. So I thought it was interesting, the theory that maybe the CO2 used for insufflation in minimally invasive surgery was a mechanism or a cause. And I was trying to figure that out as it applied, let's say, when the urologist went from open radical pubic prostatectomies to robotic. And I know there was obviously a learning curve in learning how to do the robotic, but once they got past that, I'm not aware that they've ever seen a problem like that.
CO2, you would think if the CO2 gas itself was a cause, but you can still see the cancer survival differences in both of those as well. So it's still a mystery for cervical cancer.
Kevin?
All right, I think I'd like to ask Dr. Ganti this question. I think we talked about this among ourselves. Seems maybe that a Caucasian patient versus the Asian patient may have a different tolerance to weekly cisplatin versus 3 cycles. So with this Japanese trial about to finish, what's your comments?
Could you repeat the question into the
Yeah,
microphone? a little bit
the
louder?
question was, there seems to be a difference in the tolerability of cisplatin between Asian and non-Asian patients. And the study that I presented was exclusively in Japanese patients. So what are the thoughts about that being a possibility in Western countries? And this has been a topic for long debate for a long time. For reasons that are not completely clear to me, we here in the US don't seem to like 100 milligrams per meter squared of cisplatin every 3 weeks. Every RTOG trial that has been designed has used weekly cisplatin in the absence of too many good trials. And so that's almost become standard here, even though there are a few dinosaurs like myself who still stick to the every 3 weeks cisplatin. Having said that, in addition to the Japanese trial, there was an Indian trial that was published about 2 or 3 years ago, which showed the exact opposite results. That trial, which included both postoperative and definitive chemoradiation patients, showed that standard dose cisplatin 100 per meter squared was better than weekly cisplatin. The big criticism of that trial was it used a lower dose of cisplatin weekly. It used 30 instead of 40 that was used in the Japanese trial. And the other interesting thing in the Japanese trial that I found was that the total dose of cisplatin that was received was higher in the weekly arm as compared to the every 3 week arm. So the every 3 week arm, the median total dose was about 220 per meter squared, whereas in the weekly dose, it was about 250 or 260. I think at the end, rather than weekly versus every 3 weeks, I think the amount of cisplatin that the patient gets ends up being more important. And previously, we used to think that 200 was probably enough. But at that time, the choices were either 200 or 300, nothing in between. And now I think that the more cisplatin the patient can get, the better off they are in terms of outcomes. And I foresee a situation where getting more cisplatin in is probably the better way to go rather than sticking to every week versus every 3 weeks.
So I just want to add that point, that is really true in Asia, especially in China. High-dose cisplatin is rarely used because of the supportive care. In China, extremely rare that patient would accept a feeding tube. Whereas in this country, we routinely do the PEC tube. So that's why in China, they always give a low dose weekly chemo or they use different agents. I also want to add one point about immunotherapy because as you know, the Pacific trial for non-small cell lung cancer, concurrent chemoradiation therapy followed by immunotherapy, the results were very impressive. So because of that, and there was actually pretty strong desire to repeat that in head and neck cancer. So that's why the first trial is called Javelin trial. Everybody was really excited to see whether we can repeat that kind of outcome with concurrent chemoradiation therapy and without immunotherapy. So that study, unfortunately, was terminated just a few months ago and reported in ASCO. So that study actually is negative. So we cannot repeat that, concurrent chemoradiation therapy followed by immunotherapy would be better than just a chemoradiation therapy alone. So we have to be very cautious about immunotherapy.
Dr. Lin?
This question is for Dr. Benyon. So we are doing the CT-based brachytherapy now. Do you expect if we are starting to do the MRI-based, any difference in outcomes, and why?
So we do at our institution an MRI before brachytherapy, and that's fused. And I'd say more recently than MRI compatible devices now since we moved into Buffett. And so we have been getting concurrent MRI with the device in place. Really the advantage that I would foresee would be similar to what they're hoping to see on the EMBRACE-2 studies, where smaller tumors that were receiving, if you're looking at the D90, standard that like I'd shown would be between 85 and 95 gray for the dose to be received. When they looked at their patients, the small, retrospectively, the smaller tumors were receiving D90s of up to 200, or sorry, up to over 100. And so those were patients that were getting unnecessary toxicities, and that you could only decipher from an MRI, where you could see the differences between cervical cancer and just normal cervix or uterus. Whereas then in the other population with the larger tumors, especially those larger than 3 centimeters, then we're able to discriminate there and to dose escalate. And so looking there for more of a local control. But I guess in summary, we're doing MR guided. I definitely do fractions that are just CT based, especially like a complete response after external beam, or it's all within the cervix. Those are cases where I feel like the CT is going to be no different from the MR.
Thank you.
Well, I have a question for Dr. Zen. Do HPV positive patients have different treatment volumes versus HPV negative? And number 2, how do you define a negative margin after a TORS procedure?
So I'll leave that second question to Dr. Saeed, because if you look at the ECOG 3311, there's a clear definition what is considered as a close margin. A positive margin is positive, but what is considered as a close margin? So to answer your question about the volume, whether it's a P16 positive or negative as far as radiation volume, so the volume is the same, but however, for HPV positive disease, the dose is different. And look at the HN002, the dose is 6,000, and for low risk area, it's 4,800 centigrade. Whereas for traditional advanced stage head and neck cancer, we do 7,000, and we do dose painting to 63 or 6,000 for microscopic disease. So the volume is the same, but dose actually is a different norm.
Thanks, Ken. So with regards to the margin question, I think most trials right now are using less than 3 millimeters to be the cutoff for close margin for most tonsillar and oropharyngeal cancers. And so it's a little bit less, obviously, than the 5 millimeter cutoff we typically use for most other head and neck subsites. Important to note, some of the data I sort of alluded to during my talk shows that the deep margin often is not going to be much more than about 1 to 2 millimeters away from the tumor. I think the average in some studies that have looked at pathologic specimens has been around 1.7 millimeters from the deep aspect of the tumor to the edge of the superior constrictor muscle. And so there will be many cases, usually for more extensive tumors, especially bulky T2 tumors, where the margin will be close.
Any other questions from the audience? So I have a question for Dr. Benyon. You mentioned the retro-EMBRACE data suggesting that our package time for cervical cancer has to be 7 weeks potentially, down from our 8 weeks. Has that impacted how you schedule your first fraction? Does it change your applicator choice, do you feel, because we may be starting at a different time point than prior years?
For me, I find that it hasn't changed as much as good as that looks to improve by 1 to 2.5%. I find that, like I had said, there are a lot of patients that I'm looking to downstage enough to move them from an interstitial to an intracavitary. And in those cases, I certainly wait because I think that the morbidity of treating a larger volume might not be worth that possible retrospective 1%. But then where there are cases where I can, and I'm confident what my applicator will be, if it's intracavitary, then I might insert one of those during an external beam week, and that often just that one insertion will buy me the week.
Thank you. Well, that concludes the head and neck and gynecologic cancer session. We will take a 20-minute break and return for the last session at 3:20.